On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Alan Zacharias. Dr. Zacharias is board certified in neurology with added specializations in nerve and muscle disease. He received his medical degree from the University of Mississippi and completed his neurology residency at the University of Virginia. He then completed a fellowship in electromyography and neuromuscular disease at Emory University. Some of the most common conditions Dr. Zacharias treats are migraine headaches, stroke, memory loss, dizziness, multiple sclerosis, seizures, Parkinson's disease, and peripheral neuropathy. He sees patients at Associated Neurologists in Boulder. Welcome, Dr. Zacharias.
Good evening. Hi, nice to see everybody. Well, thanks for spending some time this evening with me. We're going to talk about stroke, a condition that sadly affects a large number of Americans. We're going to talk a little bit about what a stroke is. We'll talk about some demographics. We'll talk about risk factors. We'll talk about how it happens, the different mechanisms of stroke, and how you can treat it. But importantly, how can you prevent it in the first place? Because once a stroke occurs, it can be really difficult to get through it. Many people do, and we're in a better position now to treat than ever before. But we'll explore that, and we'll explore issues about the heart, a very important source of stroke in different populations of patients with heart disease and sometimes not even knowing you have heart disease. So we'll talk about some of the innovative treatments that are available for intervening with stroke and innovative treatments on cardiac or heart conditions that can lead to stroke or put you at increased risk. So my pleasure to be here. I look forward to answering questions as we get through it, and I'll try to hit on the things that I know are the most common questions people ask. We'll work through the slides, and we won't literally read every slide. They're there for your detailed reading if you like. I've learned from previous lectures that some of you are super scientists who spent a career in the field of medicine or other fields in science and enjoy reading fine detail, so that's there for you. And others of you have said, please keep it simple. I don't want too much detail. That just confuses me. So I'm going to try to make things as in the middle as possible to make as many people as possible feel informed. So thank you for your considerations as we try to hit as many people's level of knowledge as possible. Well, it turns out that May is National Stroke Awareness Month. And that means not only May is an important month, all months are important, but we want you to be aware of stroke, and we're going to spend time focusing on the details and why it matters to be knowledgeable about stroke. We want you to stop the primary risk factors and what happens after a stroke, stop the bad effects of stroke. We're going to teach you to act fast, and we're going to talk about spreading hope about a disease or a condition that isn't as ominous as sometimes people portray. You want to know how to reduce your stroke risk, how to recognize stroke symptoms, and very most importantly, more than ever, please call 911 if you think a stroke is occurring. It is one of the leading causes of death in the United States. Some nearly 800,000 Americans suffer stroke each year, and that's only growing. It's a reflection of our demographics. As our baby boomers are aging and trying to thrive, we want to keep you all safe, but it's a large population of people that is going to lead to a lot more illnesses that affect people as we age. That death rate, 134,000, is certainly higher than that by now, but that's an estimate of how many people die per year of this terrible condition sometimes. The 96 to 2006 increase, that's a reflection of how much we've done to progress. For those of you who don't know, what happened in 1996, this would be a trivia question. If you get it, you get a gold star. That is when we first started utilizing data from the NINDS trial, which was the pivotal trial that told us you can give someone a clot buster and help that individual survive a stroke. Made a huge difference. Stroke deaths fell 33.5%, and the number of deaths fell by 18.4%. That medication is the so-called clot buster, tissue plasminogen activator, and their different forms. Something called tenecteplase has now been our go-to product. But these are the magical treatments that no, they don't solve everything, and not everybody can get them, but they are opening up opportunities for survival and improved quality of life in a very meaningful way. Over 6 million people survive stroke. That's a lot of people who have to deal with disabilities, and we're going to talk about that. One of the leading causes of adult disability. Up to 80% of all strokes are preventable through risk factor management. And I'm going to talk about what risk factor management means. What are those risk factors? Sadly, on average, someone suffers a stroke about every 40 seconds. We're going to touch a little bit on demographic groups. First, with women and stroke, it turns out that strokes kill more than twice as many American women every year as breast cancer. More women than men die from stroke, and the risk is higher for women due to the higher life expectancy. The longer you live, and women live longer than men, the more likely you are to have a stroke. And for not entirely clear reasons, women suffer greater disability after a stroke than men. There's been a bit of a surge in the mid-age range, 45 to 54, probably related to increased risk factors, high blood pressure, obesity, diabetes, and not clearly associated with any hormonal issues, but that's a statistical fact. Among the African American population, it's nearly double that of the white population, and most African Americans are more likely to suffer more severe impairments, twice as likely to die from a stroke than Caucasian population, and a lot of it is related to the risk factors. Hypertension, which is high blood pressure, diabetes, obesity, smoking, and a condition that is much more common in the African American population referred to as sickle cell anemia, where the red blood cells can block arteries, they don't flow smoothly. In our Hispanic population, there's also higher incidence than in the Caucasian population, increased risk for all types of strokes and TIAs. TIAs are the minor events that aren't associated with actual tissue damage, but they're temporary impairment of blood flow. But they're indicative of a potential stroke, and I'm going to talk about that some more soon. Also, the knowledge gap for information about stroke. We need to spread the word better. Part of that is the lack of communication always in the Spanish language, and for individuals who migrate who don't have fluency in English, there aren't always as many resources as there should be to share information about stroke across all different languages and ethnic groups. Many different well-known people that many of you have heard of and would have recognized these names have had strokes over the years. So what is a stroke? A stroke is a sudden damage to the brain caused by one of two reasons. You either block blood flow because an artery has a blood clot within the artery, or a blood vessel ruptures and there's bleeding into the brain tissue. We use the word ischemic when we're referring to a clot. Ischemic means a loss of blood flow, and that's about 87% of the strokes. The other 13% are from bleeding strokes, which can range from mild to catastrophic and fatal, and they come in different forms. Small vessels may rupture, or an aneurysm may rupture, and they are typically much more devastating than blocked arteries. This is a cartoon that demonstrates on the slide the area of plaque that can block a carotid artery. That's the internal carotid artery shown there with the yellow plaquing. Plaque, by the way, builds up over decades of life. It starts as early as our teenage years, and you'll see streaks inside of vessels. And we know that the earlier we hit the ideal diet, the better off we are. Those of us who didn't grow up with ideal diet of plant-based eating are at much higher risk than individuals who grow up without much red meat, not the fried foods, all the things throughout my life I grew up around throughout the Deep South. But it's everywhere. Everyone likes fried food. Everyone likes fatty foods. But you got to get conditioned early. So if you're raising young kids and grandkids, try to ingrain in them that green is good, healthy is good, colored foods are good. If it comes in a box, not so ideal. If you can pick it at a market, much more ideal. So try to think of the Mediterranean-based diet when you're contemplating what to eat. If you can envision going to the coast of Italy or France, what you'd pick up in the market, fresh vegetables, fresh fruit, emphasis on that. It's good for all of us for a lifetime. So what are some of the symptoms of stroke? Any sudden acute set of symptoms can potentially be a stroke, but some of the more common ones will be a sudden onset of a headache, particularly a severe headache, something you've never had before. We classically would say to somebody in the emergency room, have you ever had a headache this bad before? And if they say, this is the worst headache of my life, then it is a bleeding stroke until proven otherwise. And we will do a lot of testing to make sure it's not that. Trouble seeing out of one or both eyes. You might lose vision in an eye. You might have double vision. Sudden dizziness or trouble walking. If you abruptly lose your balance or abruptly start spinning, it isn't always a stroke, but when it's very prominent, you should always consider that possibility. It could be trouble communicating or confusion. You may be communicating with a loved one and suddenly they just don't make sense and you'll immediately recognize it. Well, make sure as best you can that this is not indicative of a stroke, and when you're not sure, what do? Call 911. Don't wait and figure it out. Let the experts figure it out. They'll thank you later if it turns out they get to go home. We'd much rather you overestimate than underestimate what something might be. And sudden numbness or weakness affecting your face or your arm or your leg. That's a very typical feature of many types of strokes. So we have this acronym, BFAST, standing for balance, watching for sudden loss of balance when that happens to somebody. Eye problems, any kind of visual change, whether it be the loss of vision or double vision. Looking at the face, see if the person has any asymmetry in the appearance, have them smile, close the eyes, wrinkle the nose, look to see if the face looks symmetric. Few of us have perfect facial features. We aren't all blessed with that, but those of us who have people who know us will say, oh no, that's his or her usual face, whether we like it or not, and then we wind up checking to see if it's moving correctly or not. If it's not moving correctly, even if it's not a beautiful face, go to the ER. Check the arms. Have a person put the arms in front, hold them steady, even ask them to close their eyes. If an arm starts drifting down, that's a stroke until proven otherwise. Speech. Ask a person to speak a simple sentence, count out loud to 10, say the ABCs, anything that gives you a clue as to whether that speech is actually okay or not. And again, call 911 as the default. You can do all the examining and other features later, and if the rescue squad comes and the sense is, no, we made a mistake, you don't have to go to the emergency room if everything is resolved and it becomes more clear what's happening, but give them a chance to get there and have life-altering interventions. So now I'm going to give you more detail on defining TIA, because many of you have heard of it, and many of you are a little confused about exactly what that means. The letters stand for transient, meaning brief, ischemic, back to that word, impaired blood flow is ischemic, and attack. So it's a sudden attack on the brain. Instead of a heart attack, you might as well think of it as a brain attack, but it's brief usually. It is a warning sign of a future stroke and up to 40% of people who have a TIA will have a stroke somewhere in the future. It's very front-loaded, meaning if you have a TIA or a warning, the first 24 hours is the greatest chance that you may have a stroke. As you move away from the onset, it'll drop significantly in that risk. Over time, it drops down to about a 5% risk per year. It's the reason we want urgent evaluations. It's the reason the standard of care is to get an evaluation within 24 hours of all the key structures. That's the brain, the arteries, the heart. We often need to admit you to the hospital overnight. Sometimes we can complete an evaluation safely in an emergency room setting, but because of the risk of stroke in that first 24 hours, we like to see you get through it solidly over that 24 hours. So bear with us when we say, please don't go home for 24 hours. Give us a chance to protect you from the irreversible, sometimes, stroke episodes. And that immediate attention is important because sometimes a TIA starts, you get better, and you would say, well, I got better already. Maybe I'm just going to wait this out. That's not a good call. You're better off going to the hospital saying, I just had this event occur. I feel better, but give them a chance to evaluate it because you might have a nearly occluded artery, and this has been happening plenty of times in hospital settings. Person feels fine after 20 minutes, and then 20 minutes later or a few hours later, they actually have a stroke, and it turns out they had an artery that was almost blocked, opened up, and then does completely block. We really have a chance to do things to protect you, so don't underestimate the value of being in a hospital setting with expertise to help you. A few myths and reality. The myth is stroke is not preventable. Up to 80% of strokes are preventable. Now, most of that prevention is our diet. It's critical. We generally do a very poor job at eating well in this country and many countries, and most of the countries where the Western diet has been adopted, guess what happens? Heart disease and strokes go up substantially. Infiltrating other countries with McDonald's is basically just wrong. We need to allow people to focus on the healthy diets, but you can hit the diet early and never change your pattern. It's also never too late to change your diet. Strokes cannot be treated. Well, absolutely untrue. There was a time when all we could do was give someone aspirin and watch them and not be able to intervene. That started to change many years ago. Specifically, it was in 1996 when you could give this clot-busting drug. And since that time, we've been able to increase the window of time where you might potentially get the treatment, initially from 3 hours up to 4.5 hours. And now studies are being undertaken regularly to look how far we can expand that window. And even if we can't give you the IV medicine, say it's been 6 hours later, but you have a blocked artery, we have the ability now to put catheters inside of an artery, take out the clot and restore blood flow, and take someone from a severe deficit to a nearly normal state, and sometimes normal. It is very dramatic over the last 10 years, particularly the last 5 years, how much more opportunity we have to intervene and help. That keeps getting better and better. The windows of opportunity get better. Another myth I want to let people know, if you wake up and have a deficit, or a loved one of yours wakes up having gone to bed fine, and suddenly they can't move aside, they could very well still be a candidate for going in there and opening up the artery with a catheter. Can't get the IV at that point, but it is no longer the case that they're excluded just based on time alone. If you have a blockage in a major artery, we will recommend attempting to get that clot out of there. Sometimes people say, isn't a stroke something that happens in the heart? And the answer is no. The stroke can be a source of a blood clot that goes to the brain, but it's an attack on the brain. It's an injury to the brain. Stroke refers to brain, heart attack refers to the heart. It's a myth that stroke recovery is over after 6 months. So No longer should you say, well, what's the point? I'm not better, so I shouldn't try anymore. We should just give up. It appears that you can keep improving for the entire lifetime after you've had a stroke, so we don't give up. It's stunningly expensive to care for individuals who have stroke. The cost of care is expensive. The incredible cost to caregivers, uncompensated care, is enormous. Many people quit their jobs, give up what they would otherwise be doing to take care of loved ones at tremendous cost. And people who are struck when they're still active and working, that could be the end of a lifetime of work and earning incomes. So it's really a true terrible condition for which we need even more interventions. And they're coming, and they keep getting better. I promise it keeps getting better. Your opportunity to be saved through intervention is better than it has ever been in the history of care of stroke. So some guidelines to follow, things you should pay attention to. If you don't have a primary care provider, please get one. They're the best source for routine screening. They are trained and educated to help prevent you in the first place from having a problem. That is their goal. They will check regularly your blood pressure. They will screen you for blood pressure. If you're curious about your own blood pressure and say, I just don't care to go to a doctor, at least go to the local pharmacy, put your arm in a blood pressure cuff, check it out. If it's above 140/90, seek medical attention, not emergently, but recognize that you might be at risk of a problem that needs treatment. Know about atrial fibrillation. Well, that's something that can be screened through your physician. You may or may not know if you have atrial fibrillation. That's a funny heartbeat I'm going to talk about more later. But you might feel fluttering in your chest. Atrial fibrillation is a major risk factor for stroke. If you smoke, try to stop. It's as simple as that. If you do drink alcohol, alcohol increases the risk of stroke. But if you drink, make it limited. Classically, we have said a single drink for a woman, 2 drinks for a male. More recent guidelines suggest that's probably even too much. None is best, but if you do drink in a social setting, as many people do, make it as limited as you comfortably can, and it'll pay off in the long run. How about cholesterol? Bottom line is get your cholesterol checked. At some point, everyone needs to know their numbers. And it's particularly important to know what your LDL cholesterol is. That's the bad one. That's the one that accumulates and goes into the arteries. The HDL is the good one. HDL that's high is going to balance out often an LDL that's high. But you still want to know what it is. You still want to know if you meet the criteria for treatment. Not everyone has to go on a statin, but if you have high risk factors, it might be a life-saving thing to do to go on a cholesterol-lowering drug and always revert back to emphasis on a healthy diet. Screening for diabetes, it can sneak up on you, particularly as you get older, particularly if you're overweight, and if there's a strong family history. Again, through your primary care, but you can get screening done in many different free settings. Make exercise a part of your daily routine. It is easier to say than do. I'm amazed how many times I don't actually exercise, and I have every reason in the world to exercise. But sometimes you're busy, and sometimes it seems hard. But even if you're in your office, take 2-3 minutes out of the hour, do some squats, stretch, move about, maybe carry some little dumbbells, but do something to move regularly. Keep your body going. Exercise is very important for preventing the accumulation of problems within arteries. Keep your salt low. Try not to add the salt, and keep the diet low in the saturated fats in particular. And never trans fats. Always avoid that. Labeling nowadays pretty much will tell you if it's in there. If it's there, don't eat it. If you have circulatory problems, let's say problems with cold feet, your toes are blue, you're not sure what's going on with that, have it checked out. Arterial disease can be an indicator of disease throughout the body, brain, and the heart. And if you start having sudden neurologic symptoms, get that 911 number quickly and off to the hospital to figure out if you're going to be a candidate for a life-saving intervention. But why don't we respond to things like this? It's the million-dollar question, isn't it? Why don't we exercise? Why don't we finish our projects? Why don't we do certain things we know are in our best interest or will improve our environment in a variety of ways? Well, sometimes we don't recognize symptoms. That's why I've tried to spell out some of the symptoms to look for. Denial is powerful. It's a defense mechanism. Simply saying, I don't know, I'm too young for that. That's a form of denial. It's a bit self-protecting, but it's not a smart thing to do. You've got to be a little more humble and say, I don't know, I'm not sure what this is. I'm going to go ahead and check it out. And don't be embarrassed. We aren't going to embarrass you if you come to the hospital and we say, no, it's not a stroke. Thank goodness is what we're going to say. There's a belief that nothing can be done. I heard there's nothing you can do about this. Not true. There's a ton we can do, especially in that first several hours after something starts. A very legitimate question and concern, and quite real, is what about cost? If someone doesn't have insurance, it's extremely expensive to get care. Even if you have insurance, no one has a small deductible. We all have big deductibles. That's another reason, but the trade-off is not worth not seeking it out. There's just too many advantages and too many ways to get assistance and support, and don't let that be the reason you don't seek care. Often people say, well, this will probably go away, and it may very well, but as I said before, it may go away and come back in a matter of minutes, so don't take that chance. And then there is fear and lack of trust. It's, I don't know, every now and then someone comes in to see me and say right off the bat, doctor, I just want to let you know I don't really like doctors, I don't like hospitals, I'm here because my wife said I have to come. So it's an interesting way to start a conversation, but it's honest. And many people have had bad experiences. They've been frustrated. You sit around all day waiting for care. You don't know who you're going to see. Primary care tends not to go to the hospital anymore. So you say, well, I don't even know who these people are who come in to see me. It can be unsettling, but try as best you can to come to the site where our true, honest goal is to try to help anybody who comes in. And if you've had bad experiences, I'm sorry that's happened, but don't let that hurt you, because it doesn't hurt the people who were rude to you in the first place. Come get the care you deserve. We have a stroke program here. We're a certified stroke center. We just had another evaluation of our program with good reviews, and we continue to get awards. We have some wonderful staff through our emergency room, our ICU, our imaging departments, and an enormous number of people through our pharmacy, everybody making your chance of surviving a stroke greater by working as a team. And we are recognized for our work together. We have a constant review of our guidelines. We always do case reviews. We always see where we could do things better. And we are striving to shorten the time from when you arrive to when you can get life-saving treatment. It is part of what we do at BCH, and most hospitals are doing this as well. The hospitals know it's important. I mentioned this clot-busting medicine known as either TPA or tenecteplase. These are medicines that you will receive quickly if you're a candidate. We try to get you treated within 15 minutes is the goal. We certainly often can't do that for various reasons, but we are striving to get you treated as quickly as possible. You can come to the emergency room, get to a scan, have a scan completed within 5 minutes, have an assessment, and within 15 minutes have an IV medicine pushed into your vein to potentially destroy or remove a clot. If, for example, you have a major artery blockage and it needs to be removed, there are a variety of devices that can be put in to the artery to remove that clot. If you came to our facility, you would be transported either via ambulance if the weather forced it, or ideally through a helicopter you'd be flown to Swedish Hospital, who we have a contract with, who provide extremely good, rapid care to remove clots when appropriate. And we have case after case showing up later, thanking the team for getting them the right care. They do a great job of removing clots. If you have bleeding, it's an entirely different process. You do not give someone a blood thinner who has bleeding into the brain. Instead, you stop the bleeding as best you can. Usually it stops on its own, but sometimes a surgeon has to remove some of the blood through either a hole in the skull or take off a large part of the skull if there's major swelling. That can even happen in the setting of certain kinds of severe strokes. It's rare, but sometimes it's needed. The clipping and coiling is referring to putting clips on an artery that has an aneurysm on it, or filling the aneurysm, which is just a bulging of an artery, with some coils of little fine metal material or sometimes other material that goes into that and blocks it so no more clots can come out. Can you recover from a stroke? Sure. 10% can recover completely. That number is getting better as we have intervention sooner and sooner. Another 25% with minor impairments, moderate to severe, and 40%. And then 10% require care with chronic care in a care facility. And in the range of 15% of people will die after a stroke. It can be an immediate or quickly life-threatening event, but most people can survive, and more people are having good survival. There are many types of therapy you can have: physical therapy, occupational therapy, speech and cognitive therapy, and recreational therapies. So much about your life can change. I won't read all of these, but these are the impacts on daily life, the things you enjoy doing, changes in eating and dressing and sexuality and just feeling good. All of those things can be impacted by a stroke. All of the different rehab approaches range from in-hospital facilities to outpatient facilities and home care. So what does the National Stroke Association focus on? It's reducing the incidence and impact of stroke. It's advocating for prevention. It's lobbying for care. It's lobbying to make costs affordable. It's educating people like me and people who care for those who have strokes. There are meetings and opportunities for all of our staff to learn more about how to care for individuals with stroke, and we do that regularly. That's the number for the Stroke Association. I'm going to borrow some of the slides from my friend, Dr. Iyengar, who's a cardiologist here and does interventional work and can do some very fascinating procedures. He and I have spoken together in the past on this topic, and he's talked on stroke and the heart himself individually. But I want to give you just a highlight of a few different things. The stroke causes, as I mentioned before, range from clotting to bleeding. But within the heart, you can have atrial fibrillation. That's from that LAA, refers to the left atrial appendage. And you can also have strokes of unknown cause. That's the word cryptogenic, which I'm going to talk about in several more slides. If you have a PFO, which is a patent foramen ovale, that's an opening between the top chambers of your heart. A clot can go through there. For example, if you have a clot in your legs, it can sneak up through the heart and get to the brain instead of going to the lungs where it would normally go. And I'm going to explain how does that happen, how often is this present, and what can you do about it. This is a slide showing just many parts of the heart that can have problems. And if you want to read about any of these topics, you just type in those words in Google and you're going to see a large amount of information. So we won't talk about all of them, but we're going to talk about atrial fibrillation first and then this hole in the heart thing, the PFO. Atrial fibrillation means a funny heart rhythm. It's, instead of being a single pump, 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 it flutters and there's not a nice efficient pump. And when that occurs, blood doesn't move very smoothly and it can accumulate and it can particularly accumulate in a space in this top chamber of the heart on the left side called the left atrium. And in the left atrium, there's a little space that it's like a little pocket of tissue that can store blood in there if it's not being pushed adequately, and you'll get clots in there very frequently. How do you know if you have atrial fibrillation? You don't always know. It's often silent. But if you get lightheaded suddenly, you have palpitations, rapid beats in your heart, that can make you worry that could be present. You might feel short of breath. There are many reasons it can occur. So if you've had high blood pressure or heart attack, or you have known heart disease, abnormal heart valves, born with an abnormal heart, thyroid problems, or even excessive alcohol, excessive caffeine, tobacco, they can increase the risk of your heart going into a funny rhythm. You diagnose it with an electrical study, an EKG, but not every funny rhythm is atrial fibrillation. There are many reasons you can have a funny rhythm, so it has to be investigated and sought out for the great detail. Nowadays, you can have a monitor placed in your chest if necessary, and it can stay in there for 3 years. And at the recent Academy of Neurology meetings just 2 weeks ago, there were reports that the chance of catching atrial fibrillation dramatically goes up the longer you monitor for it. So any of you who happen to have a TIA or a stroke, we're going to probably want to monitor you for a long time, since atrial fibrillation can be sneaky and you may not even have it at the time we see you, but that doesn't mean it can't be a source or a risk factor for stroke that we need to recognize. It's treated with a variety of medications to slow the rate and make it less likely to occur. You can have electrical treatments, a variety of things, which I'm not going to go into all of that today, the way you manage atrial fibrillation. But importantly, it is a major cause of stroke. That little chamber I mentioned, that left atrium where clot can build up, that's something that is important to understand because that's an area where we can have some intervention and make a difference. Now, classically, any of you who have atrial fibrillation, and I'm sure some of you in the audience do have it, it's that common, you would historically have been on a drug called Coumadin. And then more recently, we have a new set of medicines. They're called NOACs. That means novel oral anticoagulants. They're new, they're more specific in their effects, and they, for the most part, have lower risk of bleeding complications and actually often beat the Coumadin, and you don't have to have that annoying monitoring all the time. So they've come around and been wonderful. But both agents can cause risk of bleeding. This demographic chart is just showing the number of people changing and living with atrial fibrillation. 2015 compared to get to 2050, it's almost tripling in the number. And with that larger number of people in the population, more people are going to have atrial fibrillation. It's up to 15 or 20% of all strokes are probably related to atrial fibrillation. The severity of the strokes is worse with atrial fibrillation in general. Now, why would we not only use blood thinners? Well, this is a picture of a brain where the white you see is blood. So anybody who's been put on a blood thinner is at risk of bleeding into the brain spontaneously. And though it's not a high risk, it's significant risk. And there are times when it's not appropriate to use a blood thinner. If someone's had previous bleeding, you typically wouldn't use a blood thinner. And you would have to weigh the risks and benefits. It's a common, challenging question. Or suppose someone is extremely active and says, I don't want to be on blood thinners. My lifestyle puts me at risk. I ride mountain bikes, I crash, it's what I do. I'm not going to give it up, so I'm not going on a blood thinner. Well, if that's the case, there are ways to pursue interventions. And I'm skipping through these slides that talk about fine detail of individual drugs. That's not the purpose of this talk. But I want to talk about this way to manage this with a very fascinating device. There's something called the Watchman. And the Watchman is a device that someone like Dr. Iyengar can place into the left atrial appendage and occlude it so that clots don't build up. Remember, it's about 95% of the clotting is in that area in individuals who have atrial fibrillation. So if you could occlude the space where that blood wants to accumulate, theoretically you wouldn't need a blood thinner. You are on one temporarily, but you don't have to be on that long term if that is something that's appropriate for you. It all depends on a lot of complex issues. And in fact, over the next few years, some studies are going to start comparing if putting in a more new generation occlusive device in that left atrial appendage, if it can be shown to be just as effective as a blood thinner, it could become the new standard because the risk of bleeding may be shown to be greater than the benefit of being on a blood thinner relative to having this device put in. And the more individuals who get these, the more experience our cardiologists get with it, the safer and safer it's going to become. Because obviously if you do put something into the heart, there are some seeking ways to not have to be out on blood thinner when it's not appropriate for you. And even potentially the next step over the next many years, we're going to have some data that tells us how good can we do with preventing stroke by putting in an occlusive device. So stay tuned for that issue. This next topic on the heart, the patent foramen ovale. Everyone has in our development connected to mom's blood this opening, but it closes in about 80% of us, 75 to 80%, it closes off completely, or it's so trivial it doesn't matter. But for some of us, 20 to 25% of it, it stays open, and some of it is significant size. It's left over, and by itself, it isn't a pathologic entity, but it is a conduit from the right side of the heart to the left side. And the implication of that is, if you have a clot in your legs, instead of going to the lungs and causing a blocked portion in your lung, that's pulmonary embolism, that clot can sneak over to the other side through that opening and go to your brain instead. And that's called an embolic stroke. It's called a paradoxical embolus. It's not supposed to occur. Paradoxically, it snuck over there and got into your brain. And that's part of what we seek to understand when someone has a stroke. Could that be present? And if it is that the reason for the stroke to occur? It isn't always, but we have tools to estimate the relative probability that that was the cause of a stroke. It's just this opening where the blood sneaks from one side to the other. Now, if you look at the number of people who have these openings, as I mentioned, that 20% range in normal population, no one who's ever had a stroke, and you compare that to what about people who have a stroke and we don't know why, that's up to 40 to 60% of people who have a stroke for unknown reasons will turn out to have this opening. Therefore, it's obvious to say, well, wait a minute, that must not be coincidence. Maybe that's the reason. And the answer is absolutely, it may be the reason. And so evidence has been mounting, mounting to allow us to say, oh, it's justified to close that. Initially, we had a series of studies that didn't support that. I'm just skipping to that area. This whole chart here was showing, well, there isn't any significant advantage to closing it. That far right number that says the p-value, if that's greater than 0.05, that means the study didn't really show a benefit. Well, more recently, we had a series of studies where you see all three of those numbers are less than 0.05 on the far right side. That's the degree of significance and reliability of the findings, meaning there's well below a 5% chance of there being a false finding. It tells that it's a valid study. It's justified to do it. These are the details of strokes. Again, details of the trials I'm not going to go into. That's not helpful for our purposes. For those of you who want to read the details again, it's there as an opportunity. this slide shows a cartoon of what you can do about it. So Dr. Iyengar can pass a catheter, that blue device, across the opening and deploy that device, and then he pulls back and lodges it in that space, and then it blocks the flow. And then over time, that wire mesh gets covered by normal tissue and typically sits there and protects you permanently from any clots. Very early on, there are risks of causing problems. Placing this can increase your risk of atrial fibrillation. Placing this can cause a stroke, but those are relatively infrequent. And for someone, particularly individuals under the age of 60, it's very clear that you're better off doing this than simply taking something like aspirin or Plavix. That's already been tested, and we know that this is a better approach. Lots of discussions with neurology, with cardiology, the pluses and minuses of this. I just want you to know, if it's there, it might be a source for which we can intervene and make a big difference. So we're going to continue to be exploring strategies, technologies get better, techniques get better. We're going to understand more about who shouldn't and shouldn't have closures with time. We're going to keep understanding the advantages and disadvantages of blood thinners with cardiac conditions, who absolutely should be on a blood thinner, and are there alternatives to blood thinners, and what are the pluses and minuses of all of that. So bottom line, stroke can come from many sources, ranging from cardiac issues to blocked arteries here and many other conditions. But those are the key areas that we're always focused on very quickly. Technology is advancing, intervention techniques are advancing, the skill of individual providers is getting better, everyone's knowledge is going up. We're simply getting better at not missing strokes. You are getting better at recognizing that you should take it seriously, seek care, give us a chance to do what we really like to do, which is help you. So that's the conclusion of the set of slides and the formal presentation. I look forward to a chance to answer some questions and see if I can further elicit information that you need.
Thank you so much. That was a wonderful, informative lecture, and we are having a few questions come in, and we do want to remind our audience that now is the Q&A time, and they can ask their question at the bottom in the chat box, and we'll get to as many as we can. So in no particular order here, does stroke cause Parkinson's?
The short answer is no. Parkinson's disease is due to a loss of the cells that make dopamine. Dopamine is the key chemical that helps us move in a fluid fashion. And if enough of those cells die, then you will not make enough dopamine for normal movement, and you'll wind up with Parkinson's disease. However, if you happen to have stroke in the part of the brain that controls movement, you can have what's called vascular Parkinsonism, where if you've had enough tissue damage from stroke, occasionally individuals will have features of Parkinson's disease because of their stroke. But for the vast majority of people, we don't think of stroke as a cause for Parkinson's disease.
Thank you. Remind me, is taking a statin necessary to control carotid plaque and reduce your risk of stroke?
So when it comes to reducing plaque, statins do that extremely well. Whether it's necessary or not will depend upon what your cholesterol level is and the degree of narrowing of the vessels as to whether it's appropriate to do. But let's say, for example, you have some degree of narrowing, you go get a screening of your carotid artery, and the estimate is you have maybe 50% narrowing, not in the range where we would necessarily recommend an operation, but the range where we'd love to keep it from getting any worse. And let's say your LDL cholesterol is 140. which is high. It should be less than 100. And if someone's ever had a TIA or a stroke, the current guidelines are to make it less than 70. And we know that based on your age and risk factors and cholesterol, those individuals in a case like that are probably better off on a statin than not. But it isn't universal yet that everyone who has some plaquing has to be on a statin. But it's certainly a powerful tool that you would discuss with your physician on why would I or would I not be on statins. It is important to know that there are a lot of myths about statins. They really are safe drugs for the vast majority of people. It's over and over being shown to be the case. And absolutely, statins can cause side effects. I've taken statins. I'm on a statin. The first one I hated, I felt terrible on it. And now I'm on one I tolerate just fine. So just because one goes poorly does not mean it will always go poorly. And they are really powerful drugs for lowering total plaque and helping prevent future plaque.
Thank you. This person had a subdural hematoma from a fall that has completely healed. Do you think that they should take baby aspirin again or not?
So I can't answer for an individual. It would be an error. I don't know the individual case, but I'll take it for what's stated, and I'll speak in general about people who've had previous bleeding in the head. We have some tools for predicting relative probability of bleeding. Let's say, for example, an individual has had a subdural hematoma. It's drained. It's completely healed, which is often the case, and they have atrial fibrillation. And the recommendation from cardiology is, well, you need to be on a blood thinner for atrial fibrillation. And you came to see me in the office, and I said, well, the risk of you having a stroke from atrial fibrillation is high. The risk of you having bleeding from being on a blood thinner is relatively low, even if you've previously had a subdural hematoma. So the vast majority of people, it is a reasonable thing to be able to be on a blood thinner. More often than not, you can return safely to a blood thinner, but it's a lot of careful measuring of the individual's history. So it's not an absolute contraindication. Subdural hematomas that have healed, the vast majority of times when we have those cases, we recommend that the blood thinner be used if it's appropriate. Yeah.
Thank you. Can you speak about the best treatment options for someone who survives a strong hemorrhagic stroke?
The best treatment options? Well, it depends on the source. There aren't a lot of treatments, as you've learned, if you've had a hemorrhagic stroke. There's not a lot you can specifically do once it's happened. The key is to investigate why it happened. Let's say it's the kind of a case where the person has high blood pressure and or diabetes, and the feeling was, well, one of your little arteries ruptured and bled deep in the brain. You wait for the blood to go away, and then the best thing you can do is control your blood pressure, control blood glucose, control cholesterol, so those arteries don't have a risk of bleeding again. That's important. You do the rehab therapies to try to recover. What if you've been told you have what's called amyloid angiopathy? That's a condition where a protein builds up in your arteries. They're leaky. They have a little bit of bleeding in there, and you may have had a bleeding episode related to that. Those individuals, you want to stay away from blood thinners as much as possible to prevent recurrence of bleeding. And again, you can't fix amyloid angiopathy, but you try to fix other risk factors. And if you had bleeding because of a ruptured aneurysm, then you try to fix the aneurysm. So you treat the underlying causes when you can, and if you have risk factors that led to why the artery ruptured, you treat those risk factors. That's the approach you take.
What percentage of patients with ischemic stroke are candidates for endovascular thrombectomy?
Overall, that winds up being a population of about 5%. So if you took 100 patients who come to our hospital, about 5% of them will wind up needing or qualifying for an endovascular procedure. That number's going up as windows get longer. I've seen it as high as 15% in some cases. A lot of it depends on your referral basis. Larger centers, places in Denver, may have slightly higher volumes of cases and will wind up with a larger number, but the percentage of people still runs in that 5, 10, maybe 15% of people who actually wind up being a candidate for endovascular procedures. But it does really, it keeps getting bigger and bigger, because that window that used to be just 6 hours, we now have up to 24 hours. And now studies are starting to say you can do it even in longer than 24 hours. That's not standard yet, but at the meetings I just went to, there are some studies throughout the world showing our windows may keep expanding, maybe 36 hours, if you have the right characteristics of blood flow and a chance to recover from a major blocked artery. Keep expecting that number to go up, the opportunities to intervene.
If we suspect a TIA event that happened many months ago, is it possible to ascertain if one did indeed have a TIA that happened? How do doctors assess this?
It's based on the characteristics of the story. TIA is almost always based on the story fitting, and fitting, I mean, did the set of symptoms follow a pattern consistent with a blocked artery? So if someone says, I was sitting still and suddenly I lost vision in my left eye and it lasted 20 minutes and it went away. Well, that sounds to me like probably a clot happened to your retinal artery. Or if someone says, I was sitting there, suddenly the left side of my face drooped down, I was slurring my words, and I couldn't lift my right arm, that would tell me something probably happened in the right middle cerebral artery. If someone says, well, I just didn't feel right, I was tired, I was a little confused, but I could move everything all right, and it got better, that's a little trickier. That could be more different things, because that doesn't fit just a single artery. So it's all in the details of the story. And when we do the testing, we would say, oh, you have a major blockage in a given artery, and if your symptoms correlate with where that artery is significantly narrowed, that would increase our level of suspicion that it was a TIA. So the long answer is often we can tell, even months later, if it probably was or probably wasn't a TIA.
We have a few more questions. We're going to try to squeeze in as many as we can. You had talked about BCH and how important it was to go to a hospital that was highly rated and certified in identifying a stroke early on. How do you know where to go so that you don't get a misdiagnosis and lose those precious minutes?
It's a good question. If you're choosing to go yourself to the hospital, then most hospitals you can get that answer by simply calling an emergency room. Our preference is you call 911, and ambulances have protocols that can't be overridden. They will go to the closest facility. And keep in mind, all facilities are certainly capable of managing initial information. And all of our hospitals in Boulder County have primary stroke certification, so you're safe within Boulder County. No hospital doesn't have qualified stroke care. Most places don't have the ability to put catheters in. Everybody is transferred either to the University of Colorado or to Swedish Hospital through agreements. But neither we, nor Avista, nor Longmont United do the catheters, and I don't think Long's Peak and Longmont does it either. That's the UC Health facility. I think they transfer their patients as well, and I'm not certain about Good Sam. They may do it there, but I'm not certain. So you don't always know, but at least you can know in your region everyone has stroke specialty care.
Okay. Can blood thinners cause a hemorrhagic stroke?
Absolutely can. Yep. So you can have hemorrhagic strokes because of being on any form of blood thinner, including aspirin. Aspirin is lower risk than if you're on Coumadin or one of these drugs like Eliquis, these so-called novel oral anticoagulants, but they can be associated with bleeding into the brain spontaneously, unfortunately. It just turns out most of the time their benefits of preventing stroke outweigh that potential small risk of bleeding into the brain, but they are not free of risk.
Does drinking coffee or caffeine increase the risk of stroke?
Probably minimal. It's more a risk factor for causing atrial fibrillation or maybe having some effect on blood pressure. But you can, if you have heart disease or you've had a stroke, you're not typically restricted from drinking caffeine.
How do you know if you have a hole between your left and right atrium?
The only way you can know is by doing what's called an echocardiogram. You'd have to have that ultrasound of the heart, and typically it has to be done where you get an injection of little bubbles of air into your vein, which is safe, and they can watch and see if those air bubbles cross over to the other side. The other way is to do a special test called a transesophageal echocardiogram, where you swallow a tube and they can see from inside your esophagus, really next to your heart, if there's a hole there, or if they're doing a cardiac catheterization or injecting, they can see. So that you can only know if it's there by looking. But we don't recommend anybody be screened for that, because if you have it and have no symptoms of any kind, there's no reason to close it.
This person has been on Eliquis for years. If they had a head injury, such as a fall, would you feel positive about their recovery?
No, I wouldn't be positive. So if you're on Eliquis, fall and strike your head, you probably won't have major bleeding, but your risk is higher. So for our patient population who are very unstable on their feet and fall frequently, or high risk for falling and head trauma, often that's a reason to put in that Watchman device to block that left atrial appendage if you happen to have atrial fibrillation, as opposed to staying on a blood thinner if they're repeated high frequent falls. But most people who fall don't have catastrophic bleeding. It's just you'll have higher risk if you fall, but you won't necessarily have that happen.
Okay. One last question. This person has had 2 TIAs and they've been taking Plavix. Should I consider taking something other than Plavix?
In general, if someone has a TIA and it's not related to atrial fibrillation, which is a reason to be on a stronger blood thinner, then nothing in terms of treatment seems to be better than being on Plavix. There's some debates about that. You'd have to see a specialist, me or somebody else who's a neurologist, to talk about your individual case, because there are times when we say, well, you know what, maybe we should add something, maybe you should be on aspirin and Plavix. But for the most part, that study has been done, and using aspirin plus Plavix increases the bleeding risk more than it's worth it. Or putting someone on a blood thinner like Eliquis on top of Plavix, turns out that's usually not appropriate. The caveats are, depending if you have a stent, if you have coronary artery disease, if you have a heart valve, there can be reasons that someone might be on both, so it's very individualized. But in general, no, we don't have something we'd say you should be on something more than Plavix, or there isn't something we think is better yet.
Thank you, Dr. Zacharias. This was very great tonight. Thank you.
Yeah, my pleasure.